and we're going to dive into the skeletal system. If you haven't already, please go back and do chapter 4 before you listen to this. There's no recorded lecture for chapter 4, but there's a lot of videos, there's an assignment, and reading. Make sure that you've gone through and really understand what type of tissue the skeletal system is made of, and the histology of that, because we're going to dive into that a little more in this chapter. Okay, how many functions for the skeletal system can you name? Everyone thinks of support and movement when they think of bones and joints, which is very true. That is one very important function. But there are many others, like storage of calcium, for example. We need calcium to power muscle contractions, to power electrical nerve conduction, when we need calcium to also power intracellular functions like metabolic processes. Even clotting depends on calcium. And so in the calcium is stored in non-ionic form. It's bound in a salt because it's so reactive. So the way we store majority of our calcium is in the bony matrix, the hard part of our bone. And so our osteoclasts release that calcium when our calcium levels get low, and that gives our body the ions it needs to power all these functions. The other thing is blood cell production. Bone marrow, we have two types of bone marrow, we have yellow and red marrow in the medullary cavity of our long bones, as well as in the spongy bone, which is also called cancellous bone. It contains this marrow that produces blood cells, and blood cells also, carrying oxygen. Our red blood cells is a big component, important physiologic component, but also our white blood cells, our immune function, and platelets. So it plays a role, with bone health, plays a role in all of these different functions like clotting and our immune function as well. All right, bone classification. So we got different classifications of bones. We have two, the skeleton is divided into two halves. We'll talk about those, the appendicular and the axial skeleton. So the appendicular is the pelvic girdle and the pectoral girdle and all the upper and lower extremity bones. And the axial skeleton is the spine, thoracic cage, sternum, and skull and facial bones and cranial bones. And the way we classify bones is either flat, irregular, long, sesamoid, or short bones. And sesamoid bones are these little irregular bones that are found in a couple different places, like in the tarsals as well as the patella. And then we have short bones, which are also found in the foot. And these are bones that generally come together. They form specific joints. They form supporting structures. And then long bones are the major bones that support a lot of our body weight. They produce the large joints that produce movement, like synovial joints, and cartilaginous joints, like in our hip socket. Then we have the flat bones, and these bones have a protective function, like in the cranium and sternum. And then irregular bones, we see these in our vertebrae. All right, some terminology, bone markings. It's important we understand this terminology. So on the right is a non-comprehensive list. This is just an example, but we can see there's different names for projections and depressions and openings in bone. And we use these to kind of describe bone markings as we're looking at them. And so when we think about projections that form joints, a couple different names that come into play. We have the term head. This could be like the head of the femur, for example, or the head of the rib, where the rib articulates with the spine. This is called the head. Condyle is like a round projection, and like these are found in the knee joint. We have like the lateral and medial condyle, epicondyles that form the proximal aspect of the knee joint. We can find them in the humerus, right? In the distal humerus, what forms the articulation with the radius and ulna are the lateral medial condyles of the humerus. Facets are small little depressions like that can be found within the head that form articular surfaces for joints. We can see a little example of the rib, the green rib. In the head of the rib, there are two small facets. Ramus, this is another type of terminology for projection, often described in the skull. Projections that form muscle ligaments, we have things called like different ridges, crests, spines, and projections, and there's terminology for all of these. So tuberosity If you run your hand down the front of your shin on your tibia, you can feel the tibial tuberosity, which is this kind of ridge in your tibia. Tubercle, this is a small projection point. And then you can see this picture of the pelvic girdle over here on the blue. You can see a little example of the pubic tubercle, which articulates to form the pubic symphysis. Crest, so this is like a ridge, a curved ridge. So here's an example with your iliac crest down here on the, down here on that little blue drawing. A line is literally just a line in the bone, generally caused by the closure of a growth plate. Trochanter, so this is found in the hip joint in the femur. So the head of the femur has this projection, lateral projection, which is an attachment point for our large abductor muscles in the thigh that pull the leg away, and they attach to this trochanter, which makes up the pointy part of your hip. Okay, so process is another term used in the skull. We have epicondyles, which we kind of talked about a little bit already. Depressions and openings, these are different holes and passageways through the bone where blood vessels, nutrient arteries, lymphatic tissue, and nervous system tissue are all going to pass. So we can see different terms for these. In the skull, we have a couple different terms for openings, and these are meatus, which you can look over here on the left. This is an example of the sphenoid bone and the base of the skull, which includes part of the temporal bone and the occipital bone, as well as the frontal bone. And you can see the sphenoid bone has a lot of openings in it, because this is where a lot of our cranial nerves and blood vessels pass through, and all of these have different terms. So you can see superior orbital fissure, as well as the optic canal. It's where the canal is where the optic nerve pass. The fissure is more of a linear opening. Fossa is a term for a depression. So hypophyseal fossa here on the left, that's where the pituitary gland sits in the sphenoid bone. Then you can see these large fossa or depressions in the base of the skull, and these are where different parts of the brain structures actually sit. And then foramen is a large round opening, and you can see the foramen magnum, meaning big hole basically, and that's where the brainstem passes through. And then smaller foramen, like the jugular foramen, this is where the internal jugular vein passes as it drains blood from the cranial vault, as well as different types of the other foramen are passageways of other blood vessels and different types of nervous system tissue. Okay, here is the gross anatomy of a long bone. This is the femur bone. So a couple different parts. We have the epiphysis and the diaphysis. The epiphysis is the epi upon the diaphysis, so it's the two ends of the bone. It contains a type of bone called cancellous bone, which is a spongy bone. Both areas contain marrow, but the long shaft, or the diaphysis, contains the medullary cavity, which bone marrow is essentially just blood vessels that during formation that have condensed into this spongy tissue. And there's two types of bone marrow. There's red and yellow. Red is very vascular and has a lot of blood. It's where a lot of the blood cells are made. The yellow contains a lot more lipid tissue or fatty tissue, and that is found in the marrow cavity as well. So the medullary cavity is this center hollow part of the long bone, and then that is lined with a combination of cancellous bone on the inner portion, and then the endosteum, which is a connective layer. And then we have compact bone. So this thin layer of compact bone is the hard part that gives the bone the strength. Spongy bone has the ability gives the bone strength, but in a little bit different way. It gives strength in multi-directions. So we see a lot of, the reason we have that in the head of the bone is because there's a lot of impact there. You think about when you're walking all day, running, jumping, there's a lot of different directional forces placed on the head of the bone, and that dissipates those forces into different angles so that less of that gets transferred directly into your pelvis. So as we move down towards the the distal end, we can see an example of the articular cartilage here that makes up the knee joint. We have the epicondyles, lateral medial epicondyles, and then we have the articular cartilage. That articular cartilage is left over from bone development when our bone was actually all made out of cartilage. And that becomes the articular surface for these joints. There is the nutrient foramen, which is a small passageway within the bone that allows the nutrient arteries to penetrate into the bone and supply blood to the osteocytes and keep those cells living and functional, as well as bring blood into the marrow cavity and spongy bone, where there's also some marrow, and help to bring nutrients and remove waste products. When we place an IO in a patient, we are utilizing the red marrow within the spongy bone. So when we directly place a needle into the spongy bone, it's full of little openings. And this allows for fluid and blood products or medications to be administered and to rapidly be absorbed within the vasculature of the red marrow. And that rapidly is taken up into central circulation. So bone is definitely living, definitely very vascular. And make sure we know these terms: metaphysis, diaphysis, epiphysis, and be able to differentiate those. The last little thing I'll mention is the outer covering of the bone is called the periosteum. Okay, when we look into more of the layers, we have the periosteum, you can see, is that fibrous layer that surrounds the bone. And then we have the compact bone, which is organized into specific types of matrix with cells distributed in them. And we're going to take a look at that here in a minute. And the space that these little cells take up is called lacunae. And that is just basically means a space. And the cells that produce the bony matrix, they're called osteoblasts. And these osteoblasts, as they're maturing, they're laying down this matrix around them, and they get trapped in the lacunae, and then they become osteocytes, the bone cells. And they're just sort of frozen, like Han Solo in Star Wars, like in a surrounded by a hardened matrix. And that traps those cells in the bone. Over here, we can see an example of the spongy bone. So you can see the bony matrix is organized in a different fashion, and the space that the osteocytes are occupying is found here in these little lacunae. But they're just organized slightly in a different fashion. And this sort of ring-like shape, this is like a transverse slice, so like if you were slicing a carrot and looking at it, of the actual trabeculae that make up the cancellous bone. Flat bones have a layer of compact bone with a spongy bone in between. So it's like sandwiched, and that helps dissipate impact forces and protect underlying structures, which is why we see flat bones over things like the brain, things like the heart, the great vessels. These are protected by flat bones. And so this layering allows for impact protection. It's why it's pretty difficult to fracture a sternum completely because of this layering, but it can happen. We obviously see skull fractures and all sorts of injuries like that when there's enough force applied to this type of bone. There is marrow found in here, and this is a vascular place. That's why we see sternal IOs placed, because we can actually place needles right into the sternum and give fluid into this spongy bone. This is called a diplo, just for the terminology of how flat bones are organized. The histology of bone, we have 4 main cells that make up bone. So osteogenic cells. So let's back up. The precursor to these are called myeloid stem cells, because the cells before those myeloid cells are what's called a multipotent cell. They can become different types of cells, like chondrocytes that lay down cartilage, for example. They have other lineages, but when we go down into the osteogenic line. This comes from the myeloid stem cell. However, now the osteogenic cell really can only become one thing, and that is an osteoblast. And the osteoblast is going to form the bony matrix. Blast for building up. And when, like we talked about, that bony matrix gets formed, it's going to build a surrounding network around itself, and it's going to get frozen like Han Solo into that matrix, and it's going to become a osteocyte at that point. And these little projections are are representing these little canals that exist in the matrix called canaliculi that allows for nutrients from the blood supply to make its way to the osteocytes. So the blast cells build up the bone. The cytes, once they're entrapped in the matrix, they just help maintain the mineral concentration of bone. So they're helping to monitor and balance the mineral salts that are making up bone. Osteoclasts do not come from osteogenic cells. These are actually immune cells. So they come from the monocytes, which are basically a blood cell that is made for gobbling stuff up. And we see monocytes are, more specifically, they're called macrophages. And macrophages are, PHAG means to ingest or to bring stuff in. So when we see that term, we know these cells are responsible for digesting things and breaking stuff down. And that's what they do in our immune system. We see macrophages all over the place, like in our liver. They're called Kupffer cells, for example. They have the same exact function, immune function in the liver as they do in the blood, where they're called monocytes. But in the bone, they're called osteoclasts. And they have a very specific function in the bone, and that is to break down bone to help release calcium. So as they have those hydrolytic enzymes that can break down those salts and release the mineral concentration into the bloodstream to help maintain that balance. So the clast cells and blast cells have to be working in connection with one another to make sure that your bone doesn't get too broken down, and that we're replacing broken down bone with new mineral salts. However, this process can break down as we age, and we can lose bone density very easily as we have less and less osteogenic stem cell activity, less osteoblasts, and poor mineral intake and things like that. We can start to see bone density issues. So those blast cells, like we talked about, they're building the bony matrix. You can see them here dyed in green. They're laying down this bony matrix on the outer edge of that bone, making new mineral deposits, and then they become calcified within that matrix. Here is what that looks like when they become calcified. Here's a really up-close electroradiograph of electron micrograph rather of an osteocyte, and you can see the canaliculi, these small, tiny projections that provide the nutrients to these cells to help keep them alive. Osteogenic cells, what we talked about, these are the stem cells. They're the myeloid cells that are specific to bone. They can only become the osteoblasts, which can mature into the osteocytes. The osteoclasts are the breakdown bone digesters, and they are not part of the myeloid lineage. They are immune cells called macrophages that break stuff down. So here is what that compact bone looks like. In your tissues chapter, you should have already been looking at this. So we have a couple different terminology. So here is the connective periosteum. And then as these bony matrix is laid down in compact bone, it makes like ring-like structures. And this reminds me of a tree trunk, kind of if you were to cut and look down at a tree trunk. So the rings, you can see the osteocytes occupying the lacunae, and you can see the canaliculi projecting from them. Don't get confused with canaliculi as this large central opening. That is called the central canal or Haversian canal. And the Haversian canal is where small nerves pass through nutrient veins and arteries, as well as lymphatic tissue. So the bone has a lot of not only vasculature, but it's supplied by the lymphatic system as well as the nervous system. And this nervous system not only provides sensory function to bone, obviously it hurts to break a bone, but think about if you're moving your leg or your arm, how do you know that your joint is moving? How do you get that sensation? Well, there are specialized receptors in the muscles and located near joints that are called proprioception receptors, and those detect movement. So there's a lot of different sensory functions located in and around bone, particularly around bones that move. And then when we look at it in the radiograph here, so I keep saying radiograph, the micrograph here, this is the, you can see the concentric rings. This whole structure, this round structure is called an osteon. And in the center of the osteon is the central canal. And then these little tiny projections from each one of these black dots, these are the osteocytes, and those little projections are the canaliculi. This is going to be the spongy bone here on the inner part of the medullary cavity, also found in the diaphysis, and you can see the difference in structure. It has this lattice-like structure. So here's what that spongy bone looks like, kind of zoomed in on. You can see how the bone osteocytes are built in this ring-like structure. The osteocytes are on the outer edge, and the matrix is within the center. So these little trabeculae are hardened like compact bone, but they have lots of spaces and voids. This is where the vasculature and the red marrow exists. And so that red marrow is what, like I said, when we drill an IO into the head of a bone, that's where we're injecting the fluid. The blood supply, this is kind of what that looks like. We have the nutrient foramen into the bone, and this passes into the medullary cavity, also into the spongy bone. We have lots of vasculature. And again, marrow is really just condensed vasculature that has developed during early development. The first blood vessels that are those nutrient arteries condense and condense and condense until we get this like vasculature, this sponge of blood vessels, and that is where what becomes our bone marrow. Okay, so when we are developing bone, we first have something called a cartilage template, and this is in utero. As you are being developed, your bones don't just start developing as bone. We have very non-specific stem cells, and basically through development in utero, these cells are becoming more and more specific because they are taking up different roles. And that specificity comes from molecules that are created to help signal these cells to develop into a certain thing. And part of that, and these myeloid cells that we have, are originally going to produce something called chondrocytes. And these chondrocytes are going to lay down cartilage, particularly a type of cartilage called hyaline cartilage. That hyaline cartilage is surrounded by something called a perichondrium, which is this layer that kind of gives this cartilage a shape of a bone, but it is not quite bone. There's going to be two processes that we utilize to replace cartilage with bone. That process is called ossification, and we have one called intramembranous ossification. Intramembranous ossification is going to be how we make flat bone. It comes from these tissue sheets that are kind of undifferentiated mesenchymal cells that are producing collagen and cartilage and laying down these bone cartilage templates. Then as these mesenchymal cells group together, they form what's called an ossification center. And basically, these little osteoids get trapped in there, and as they get trapped, they're differentiating now into osteoblast cells. And then they become osteocytes, and this matrix forms. And this, as we form flat bone, this is happening mostly in utero, but can extend beyond after birth. We're still continually doing this. So this is what endochondral ossification looks like. This is how we form long bones. And the formation of a long bone happens in several steps. So first we have the undifferentiated mesenchymal cells, and those start to form chondrocytes that are going to build a template. And those chondrocytes you can see over here on A, that is a cartilage matrix, not a bony matrix. In the center, these will start to calcify as these cells basically are innervated by blood vessels, and we start to provide blood supply to this cartilaginous matrix. These cells start to develop into osteogenic stem cells and an osteoblast that are going to start laying down a calcified matrix. Then we get more of a nutrient artery that's going to penetrate this central area, and that becomes the primary ossification center. So we start to develop bone outward away from this central area that's going to eventually become the medullary cavity, and those condensed blood vessels are going to form the bone marrow in the medullary cavity. As the bone is developing in the primary ossification center, the heads of the bone, or the epiphysis of the distal and proximal epiphysis, are remaining that hyaline cartilage, and that's uncalcified until we get the formation of what's called the secondary ossification center, and that's where we're going to have more blood vessels entering into the heads of the bone, and then we're going to get the generation of the osteogenic cells and the osteoblasts that are lay down the bony matrix, and those vessels that are innervating that area will become that red marrow in the spongy bone. Now, what's left behind is this little layer of mesenchymal cells in the head of the bone, and that's called your growth plate. Essentially, it's the remnants of this early developing cartilage matrix with these undifferentiated stem cells that can produce osteogenic cells and continue to allow the bone to expand. And so as it does that, it will expand in this linear fashion and circumferentially to make the bone longer and a little thicker in diameter. So as that's happening throughout development, those bones are becoming longer. And this happens all the way up until early adulthood at age 21-ish, when our final growth plates close. And so once our bone reaches its length, the growth plates will then finally differentiate into those blast cells, and we'll get a calcified matrix there, and that's going to be the closure of that growth plate. So here's what that kind of looks like from the growth plate zone. We have this undifferentiated myeloid cells in the chondroblasts in the upper part of the growth plate. Then we have, as it's moving into the bony matrix, we have proliferation, and this is where these are now going to proliferate into those osteogenic cells. And then maturation and hypertrophy, this is where they're becoming osteoblast cells. And then we have the calcified matrix, and then the formation of bone. And so this little area that's producing these cells is allowing the bone to grow longer and longer and longer and longer without actually fully calcifying that one area. So we have this constant little reserve until the bone gets to fully developed length, and then it will close and become the epiphyseal line. So epiphyseal plate is when it's still the mesenchymal cells. Epiphyseal line is when it's closed. Now, if you get a fracture in this epiphyseal plate before it is closed, it can really mess up bone development, because once that fracture extends through there, we can actually prematurely close that growth plate through the healing process of that fracture. It can damage those cells and replace them with non-mesenchymal cells. And then that is going to become a problem for us because that bone may not develop correctly. And so this is why growth plate fractures are kind of a big deal, because they can really affect long-term